All right, let's jump right in. Today, we're taking a deep dive into an organism that's really climbed the ranks from a lab curiosity to a major player in hospital-acquired infections. I'm talking about Staphylococcus cohnii subspecies cohnii. It's a fascinating story of a bug we thought was harmless turning into a really formidable opponent.
And this quote just says it all, doesn't it? It perfectly captures that huge shift in how we see this organism. For years, if you found Staphylococcus cohnii in a culture, the first thought was, it's just contamination. But now, the evidence is just undeniable. In the right patient, especially in a hospital setting, this is a serious pathogen.
And here's why it's on everyone's radar. The scale of the resistance problem is just staggering. We're talking about nearly 90% of clinical isolates of Staphylococcus cohnii being methicillin resistant. So this isn't just about one tough infection. It makes this organism a critical reservoir for resistance genes, kind of like an armory that can share its weapons with other bacteria in the hospital. Okay, so getting the IG right is absolutely foundational to understanding its impact. Let's walk through the whole process, starting with the classic methods at the bench and going all the way to the cutting edge of genomic sequencing.
So starting at the bench, what's its classic profile? Well, it's a gram-positive coccus. You'll see those typical grape-like clusters. It's catalase positive, coagulase negative. But here's a key trait. It's intrinsically resistant to novobiocin. And that's a really important clue because it immediately puts it into the Staphylococcus saprophyticus group and helps you separate it from other cons, like Staphylococcus epidermidis. Now, traditionally, telling the two subspecies apart boiled down to a few key biochemical tests. Staphylococcus cohnii, subspecies cohnii, is urease negative and doesn't ferment lactose, whereas subspecies urealyticus is positive on both. On paper, that seems pretty straightforward, right? But as always, the genetic story is way more complicated.
And this is where genomics is just completely rewriting the textbook. When you look at the whole genome, the genetic distance between the two subspecies is actually so vast that urealyticus might need to be reclassified as its own separate species. Think about that. It has huge implications for epidemiology because for years, we've probably been lumping two different organisms together in our data. You know, it's amazing to see how our diagnostic toolkit has evolved. We started with the biochemicals, which are still handy for a presumptive ID. Then boom, MALDI-TOF mass spectrometry came along and changed the game with its speed. For the really tough cases, we can turn to sequencing key housekeeping genes. But the gold standard now? That's whole genome sequencing. It's the ultimate tool for sorting out taxonomy and tracking outbreaks with incredible precision. So what is it that makes this organism so tough in a hospital? It's not really about aggressive toxins like you see with Staphylococcus aureus. No, its story is all about persistence and defense. And it really comes down to two main strategies.
Its number one superpower is biofilm formation. And we're not just talking about a simple layer of slime. This is a highly organized fortress. Staphylococcus cohnii builds this matrix to glue itself to surfaces like catheters and prosthetic joints. Once inside, the bacteria are basically hiding from the immune system and, crucially, from our antibiotics. And this strategy of building fortresses on medical devices translates directly into some really severe infections. You see it most often as bloodstream infections that start from a central line, or these devastating infections of prosthetic joints and heart valves. It's also a really significant cause of late-onset sepsis in very vulnerable premature babies.
Okay, so how in the world do we manage these infections, especially with such high resistance rates? Well, there are no guidelines written specifically for Staphylococcus cohnii, so we have to borrow principles from how we treat other coagulase-negative staph. Let's look at the current thinking. Before we even mention a single antibiotic, we have to talk about the golden rule. Source control is everything. I mean it. Because these infections are living in a biofilm on a piece of plastic or metal, antibiotics alone are almost guaranteed to fail. To have any real chance of a cure, you have to remove the infected device. It's absolutely non-negotiable. So, reading the susceptibility report correctly is obviously critical. These are the EUCAST breakpoints. And the one I really want to point out is cefoxitin. A cefoxitin MIC over 4 is your signal for mecha-mediated methicillin resistance. That means you report the isolate as resistant to all beta-lactams, penicillins, cephalosporins, carbapenems, the whole lot.
Let's take a common scenario, a catheter-related bloodstream infection in an adult. If you compare different guidelines like the Dutch SWAB guidelines and international ones from IDSA, you see a lot of agreement. The core principles are identical. Start with empiric vancomycin and get that line out ASAP. The only real wiggle room is some slight differences in how long to treat after the line is removed. Now, when you get into pediatrics, and especially neonates, vancomycin dosing gets a whole lot more complicated. The old way of just checking trough levels is really falling out of favor. The whole paradigm is shifting to targeting a specific area under the curve to MIC ratio, that AUC to MIC of 400 to 600. It's a much more sophisticated way to maximize the drug's effectiveness while trying to minimize the risk of kidney damage. You know, when you think about it, these are primarily infections we introduce during medical care. That means the single most effective weapon we have against Staphylococcus cohnii is just preventing it in the first place. So let's look at the measures that really move the needle.
These care bundles are the absolute bedrock of modern infection prevention. It's a defense-in-depth strategy. Obsessive hand hygiene, using full sterile barriers when placing a line, prepping the skin with chlorhexidine, and maybe the most overlooked one, every single day asking the question, does my patient still need this catheter? The whole goal is to stop the patient's own skin bacteria from getting a free ride into a sterile part of the body.
And this all leaves us with a really big, forward-looking question. The line between a harmless bug living on our skin and a dangerous pathogen is getting blurrier and blurrier. Our own normal flora are becoming armed to the teeth with resistance genes. So how do we adapt our stewardship programs for that? How do we manage antibiotic pressure when the biggest reservoir for resistance is the patient right in front of us?
Just so you know, all of the information we covered today was distilled from a really comprehensive review of the scientific literature, all done using a Gemini deep search. For anyone who wants to go deeper into the data, you can find a complete list of all the cited sources in the notebook document that's linked with this explainer.
And hey, we'd love to hear from you. Your feedback, your questions, your own clinical experiences. They're all incredibly valuable to this community, so please share them down in the comments. And of course, if you found this helpful, don't forget to subscribe for more explainers like this one. Thanks for tuning in.